Spirometry is the most common of the pulmonary function tests, measuring lung function, specifically the amount and/or speed of air that can be inhaled and exhaled. Spirometry is an important tool used for generating pneumotachographs, which are helpful in assessing conditions such as asthma, pulmonary fibrosis, cystic fibrosis, and COPD. Indications: Spirometry is indicated for the following reasons: to diagnose or manage asthma, to detect respiratory disease in patients presenting with symptoms of breathlessness, and to distinguish respiratory from cardiac disease as the cause, to measure bronchial responsiveness in patients suspected of having asthma, to diagnose and differentiate between obstructive lung disease and restrictive lung disease, to follow the natural history of disease in respiratory conditions, to assess of impairment from occupational asthma, to identify those at risk from pulmonary barotrauma while scuba diving, to conduct preoperative risk assessment before anesthesia or cardiothoracic surgery, to measure response to treatment of conditions which spirometry detects, to diagnose the vocal cord dysfunction. Spirometry testing. Spirometer. The spirometry test is performed using a device called a spirometer, which comes in several different varieties. Most spirometers display the following graphs, called spirograms: a volume time curve, showing volume along the y-axis and time along the x-axis, a flow volume loop, which graphically depicts the rate of airflow on the y-axis and the total volume inspired or expired on the x-axis. Procedure. The basic forced volume vital capacity test varies slightly depending on the equipment used. Generally, the patient is asked to take the deepest breath they can, and then exhale into the sensor as hard as possible, for as long as possible, preferably at least 6 seconds. It is sometimes directly followed by a rapid inhalation, in particular when assessing possible upper airway obstruction. Sometimes, the test will be preceded by a period of quiet breathing in and out from the sensor, or the rapid breath-in will come before the forced exhalation. During the test, soft nose clips may be used to prevent air escaping through the nose. Filter mouthpieces may be used to prevent the spread of microorganisms. Limitations of test: the maneuver is highly dependent on patient cooperation and effort, and is normally repeated at least 3 times to ensure reproducibility. Since results are dependent on patient cooperation, FVC can only be underestimated, never overestimated. Due to the patient cooperation required, spirometry can only be used on children old enough to comprehend and follow the instructions given, and only on patients who are able to understand and follow instructions. Thus, this test is not suitable for patients who are unconscious, heavily sedated, or have limitations that would interfere with vigorous respiratory efforts. Other types of lung function tests are available for infants and unconscious persons. Another major limitation is the fact that many intermittent or mild asthmatics have normal spirometry between acute exacerbation, limiting spirometry's usefulness as a diagnostic. It is more useful as a monitoring tool. A sudden decrease in FEV1 or other spirometric measure in the same patient can signal worsening control, even if the raw value is still normal. Patients are encouraged to record their personal best measures. Related tests: spirometry can also be part of a bronchial challenge test, used to determine bronchial hyperresponsiveness to either rigorous exercise, inhalation of cold dry air, or with a pharmaceutical agent such as methacholine or histamine. Sometimes, to assess the reversibility of a particular condition, a bronchodilator is administered before performing another round of tests for comparison. This is commonly referred to as a reversibility test, or a post-bronchodilator test, and is an important part in diagnosing asthma versus COPD. Other complementary lung functions tests include plethysmography and nitrogen washout. Parameters: the most common parameters measured in spirometry are vital capacity, forced vital capacity, forced expiratory volume at timed intervals of 0.5, 1.0, 2.0 and 3.0 seconds, forced expiratory flow 25 €75% and maximal voluntary ventilation, also known as maximum breathing capacity. Other tests may be performed in certain situations. Results are usually given in both raw data and percent predicted. The test result is a percent of the predicted values for the patients of similar characteristics. The interpretation of the results can vary depending on the physician and the source of the predicted values. Generally speaking, results nearest to 100% predicted are the most normal, and results over 80% are often considered normal. Multiple publications of predicted values have been published and may be calculated online based on age, sex, weight and ethnicity. However, review by a doctor is necessary for accurate diagnosis of any individual situation. A bronchodilator is also given in certain circumstances and a pre-post graph comparison is done to assess the effectiveness of the bronchodilator. See the example printout. Functional residual capacity cannot be measured via spirometry, but it can be measured with a plethysmograph or dilution tests. Forced vital capacity. Forced vital capacity is the volume of air that can forcibly be blown out after full inspiration, measured in liters. FVC is the most basic maneuver in spirometry tests. Forced expiratory volume in 1 second, FEV1 is the volume of air that can forcibly be blown out in 1 second, after full inspiration. Average values for FEV1 in healthy people depend mainly on sex and age, according to the diagram at left. Values of between 80% and 120% of the average value are considered normal. Predicted normal values for FEV1 can be calculated online and depend on age, sex, height, mass and ethnicity as well as the research study that they are based on. FEV1/FVC ratio. FEV1/FVC is the ratio of FEV1 to FVC. In healthy adults this should be approximately 75–80%. In obstructive diseases FEV1 is diminished because of increased airway resistance to expiratory flow. The FVC may be decreased as well, due to the premature closure of airway in expiration, just not in the same proportion as FEV1. This generates a reduced value. In restrictive diseases the FEV1 and FVC are both reduced proportionally and the value may be normal or even increased as a result of decreased lung compliance. A derived value of FEV1% is FEV1% predicted, which is defined as FEV1% of the patient divided by the average FEV1% in the population for any person of similar age, sex and body composition. Forced expiratory flow. Forced expiratory flow is the flow of air coming out of the lung during the middle portion of a forced expiration. It can be given at discrete times, generally defined by what fraction remains of the forced vital capacity. The usual intervals are 25%, 50% and 75%, or 25% and 50% of FVC. It can also be given as a mean of the flow during an interval, also generally delimited by when specific fractions remain of FVC, usually 25–75%. Average ranges in the healthy population depend mainly on sex and age, with FEF 25–75% shown in diagram at left. Values ranging from 50 to 60% and up to 130% of the average are considered normal. Predicted normal values for FEF can be calculated online and depend on age, sex, height, mass and ethnicity as well as the research study that they are based on. MMEF or MEF stands for maximal expiratory flow and is the peak of expiratory flow as taken from the flow volume curve and measured in liters per second. It should theoretically be identical to peak expiratory flow, which is, however, generally measured by a peak flow meter and given in liters per minute. Recent research suggests that FEF 25–75% or FEF 25–50% may be a more sensitive parameter than FEV1 in the detection of obstructive small airway disease. However, in the absence of concomitant changes in the standard markers, discrepancies in mid-range expiratory flow may not be specific enough to be useful, and current practice guidelines recommend continuing to use FEV1, VC, and FEV1/VC as indicators of obstructive disease. More rarely, forced expiratory flow may be given at intervals defined by how much remains of total lung capacity. In such cases, it is usually designated as for example FEF 70% TLC, FEF 60% TLC and FEF 50% TLC. Forced inspiratory flow 25–75% or 25–50%, Forced inspiratory flow 25 euro 75% or 25 euro 50% is similar to FEF 25 euro 75% or 25 euro 50% except the measurement is taken during inspiration. Peak expiratory flow. Peak expiratory flow is the maximal flow achieved during the maximally forced expiration initiated at full inspiration, measured in liters per minute or in liters per second. Tidal volume. Tidal volume is the amount of air inhaled and exhaled normally at rest. Total lung capacity. Total lung capacity is the maximum volume of air present in the lungs. Diffusing capacity. Diffusing capacity is the carbon monoxide uptake from a single inspiration in a standard time. Since air consists of very minute or trace quantities of CO, 10 seconds is considered to be the standard time for inhalation, then rapidly blow it out. The exhaled gas is tested to determine how much of the tracer gas was absorbed during the breath. This will pick up diffusion impairments, for instance in pulmonary fibrosis. This must be corrected for anemia and pulmonary hemorrhage. Atmospheric pressure and/or altitude will also affect measured DLCO, and so a correction factor is needed to adjust for standard pressure. Online calculators are available to correct for hemoglobin levels and altitude and/or pressure where the measurement was taken. Maximum voluntary ventilation. Maximum voluntary ventilation is a measure of the maximum amount of air that can be inhaled and exhaled within 1 minute. For the comfort of the patient, this is done over a 15-second time period before being extrapolated to a value for 1 minute expressed as liters per minute. Average values for males and females are 140 euro 180 and 80 euro 120 liters per minute respectively. Static lung compliance. When estimating static lung compliance, volume measurements by the spirometer needs to be complemented by pressure transducers in order to simultaneously measure the transpulmonary pressure. When having drawn a curve with the relations between changes in volume to changes in transpulmonary pressure, CST is the slope of the curve during any given volume, or, mathematically, IVIP. Static lung compliance is perhaps the most sensitive parameter for the detection of abnormal pulmonary mechanics. It is considered normal if it is 60% to 140% of the average value in the population for any person of similar age, sex and body composition. In those with acute respiratory failure on mechanical ventilation, the static compliance of the total respiratory system is conventionally obtained by dividing the tidal volume by the difference between the plateau pressure measured at the airway opening during an occlusion at end inspiration and positive end expiratory pressure set by the ventilator. Others. Forced expiratory time. Forced expiratory time measures the length of the expiration in seconds. Slow vital capacity. Slow vital capacity is the maximum volume of air that can be exhaled slowly after slow maximum inhalation. Maximal pressure. PMAX is the asymptotically maximal pressure that can be developed by the respiratory muscles at any lung volume, and P is the maximum inspiratory pressure that can be developed at specific lung volumes. This measurement also requires pressure transducers in addition. It is considered normal if it is 60% to 140% of the average value in the population for any person of similar age, sex and body composition. A derived parameter is the coefficient of retraction, which is PMAX/TLC. Mean transit time. Mean transit time is the area under the flow volume curve divided by the forced vital capacity. Technologies used in spirometers: volumetric spirometers, water bell, bellows wedge. Flow measuring spirometers: Fleisch pneumatic, Lilly pneumatic, turbine stator rotor, pitot tube, hot wire anemometer, ultrasound. See also, peak flow meter, nitrogen washout. References: American Academy of Allergy, Asthma, and Immunology, 5 Things Physicians and Patients Should Question, Choosing Wisely, an initiative of the ABIM Foundation, retrieved August 14, 2012. Expert Panel Report 3, Guidelines for the Diagnosis and Management of Asthma. National Institutes of Health. 2007. Bateman, ed. Hurd, S.S. Barnes, P.J. Busquet, J. Drazen, J.M. Fitzgerald, M. Gibson, P. Ota, K. Obin, P. Pedersen, S.E. Positiony, E. Sullivan, S.D. Wenzel, S.E. Czar, H.J. Global Strategy for Asthma Management and Prevention, GINA Executive Summary. European Respiratory Journal 31, 143 Euro 178 doi, 10.1183/090319360.00138707. PMIDA 18,166,595 ABCDEFGH Pierce, Spirometry, an essential clinical measurement. Australian Family Physician 34, 535 Euro 539. PMIDA 15,999,163 SurgeryEncyclopedia.com Spirometry tests. Retrieved March 14, 2010. MVV and MBC, Stonage Vic S., Wader, Stocks J. AL reference ranges for spirometry across all ages, a new approach. AMJ Respir. Crit. CareMed 177, 253 Euro 60 doi, 10.1164/RCCM 200,708-1248 OC. PMCA 2,643,211. PMIDA 18,006,882 A.B. Perez, L.L. Office Spirometry. Osteopathic Family Physician 5, 65 Euro 69 doi, 10.1016/JOSFP. 2012.09.003a, ABCD Lung Function Euro Practice Compendium for Semester 6. Department of Medical Sciences, Clinical Physiology, Academic Hospital, Uppsala, Sweden. Retrieved 2010. ABC Interpretation Model Euro Compendium at Uppsala Academic Hospital. By H. Hedenstra Paragraph M. February 4, 2009, Simon, Michael R. Ciancilli, Vernon M., Phillips, Brenda R., Sorkness, Christine A., Lemonsk J.R., Robert F., Seffler, Stanley J., Torsig, Lynn, Beccaria, Leonard B., Morgan, Wayne. Forced expiratory flow between 25% and 75% of vital capacity and FEV1/forced vital capacity ratio in relation to clinical and physiological parameters in asthmatic children with normal FEV1 values. Journal of Allergy and Clinical Immunology 126, 527 Euro 534 E8 doi, 10.1016/J. Jarsi. 2010.05.016 Cyprandi, Giorgio. Cirillo, Ignazio. Forced expiratory flow between 25% and 75% of vital capacity may be a marker of bronchial impairment in allergic rhinitis. Journal of Allergy and Clinical Immunology 127, 549 Euro 549 doi, 10.1016/J. Jarsi. 2010.10.053 Pellegrino R., VAGG, Brusesco V., Grapower O., Burgos F., Casabri R., Coates A., Van der Grinten Kamp, Gustafsson P., Hankinson J., Jensen R., Johnson D.C., McIntyre N., McKay R., Miller Mr., Navajas D., Pedersen O.F., Wanger J. Interpretative Strategies for Lung Function Tests. The European Respiratory Journal Official Journal of the European Society for Clinical Respiratory Physiology 26, 948 Euro 68 doi, 10.1183/090319360.05.00035/205. PMIDA 16,264,058 Kreider, Maril. Chapter 14.1 Pulmonary Function Testing. ACP Medicine. Decker Intellectual Properties. Retrieved April 29, 2011 Nunn A.J., Greg 1. New Regression Equations for Predicting Peak Expiratory Flow in Adults. BMJ 298, 1068 Euro 70 doi, 10.1136/BMJ. 298, 6680, 1068. PMCA 1,836,460. PMIDA 2,497,892 adapted by Clement Clark for use in EU scale EuroCpeakflow.com at predictive normal values, Medline plus Encyclopedia Lung Diffusion Testing, George, Ronald B. Chest Medicine, Essentials of Pulmonary and Critical Care Medicine. Lippincott Williams and Wilkins. PA 96. ISBN A978-0-7817-5273-2 Sud, A. Gupta, D. Wanshu, A. Jindal, S.K. Bambury, P. Static lung compliance as an index of early pulmonary disease in systemic sclerosis. Clinical Rheumatology 20, 177 180 doi, 10.1007 per second 100670170060. PMIDA 11,434,468. Rossier, Gottfried S.B., Zocchi L., AL measurement of static compliance of the total respiratory system in patients with acute respiratory failure during mechanical ventilation. The effect of intrinsic positive end expiratory pressure. The American Review of Respiratory Disease 131, 672 Euro 7. PMIDA 4,003,913 Lausted, C. Johnson, A. Scott, W. Johnson, M. Coyne, K. Causey, D. Maximum static inspiratory and expiratory pressures with different lung volumes. Biomedical Engineering Online 5, 29 doi, 10.1186/1475-925x5-29. PMCA 1,501,025. PMIDA 16,677,384. 1. Borth, FM. The derivation of an index of ventilatory function from spirometric recordings using canonical analysis. British Journal of Diseases of the Chest 76, 400 Euro 756 doi, 10.1016/0007-0971, 82, 90077-8. Further reading, Miller Mr., Grapeau R., Hankinson J., Brushesko V., Burgos F., Casabri R., Coates A., Enright P., Van der Grinten Camp, Gustafsson P., Jensen R., Johnson D. C., McIntyre N., McKay R., Navajas D., Pedersen O. F., Pellegrino R., Viaggi G., Wanger J. General Considerations for Lung Function Testing. European Respiratory Journal 26, 153 Euro 161 doi, 10.1183/0903193.05.000345505. PMIDA 15,994,402. External links, detailed information on spirometric testing, interpretation and physiology at spexpert.com, general information on spirometry at Spirometry Guru, detailed information on interpretation of flow volume curves including examples, general information on spirometers and spirometry, American Thoracic Society, European Respiratory Society, General Practice Airways Group.